Go ahead.
Ready? Knock. Mrs. Doe.
Hi.
Hello, my name is Daniel Butcher. I'm a PA student for University of Cumberland. Dr. Williams asked me to come in and do an abdominal exam. Does that sound right?
Yep.
All right, give me a second. Let me wash my hands up and then go ahead and get started.
Sounds good.
While we're doing this, you mind? Go ahead. Let me see your wristband here. Tell me your full name
Jane Doe.
and date of birth.
1794.
Okay, and your information matches up with mine. All right, looks like we're ready to get started here. Okay, so first thing we're going to do is we're going to have the patient lay back in the supine position. We're going to put this out, arms to the side. Make sure that the patient has time before the exam to empty their bladder. Make sure they have good adequate lighting, which this is perfect. So I'm going to go ahead now and drape the patient from the xiphoid process to the symphysis. Okay, I'm going to make sure I stay on the patient's right side and also make sure that I warm my stethoscope and my hands up so the patient doesn't feel the cold and start guarding their abdomen. Also, we're going to distract the patient on conversation as well. Okay, so now we're going to move on to inspection first. So we're going to inspect all four quadrants. So we have the right upper quadrant, left upper quadrant, left lower quadrant, and right lower quadrant. So we're going to inspect the skin for any scars, striae, ecchymosis, rashes, or dilated veins. Don't see any of those. So now we're going to inspect pulsations of the aorta and the abdomen. Typically you may be able to see just some very faint pulsations, but if they had an abdominal aortic aneurysm, you may see increased pulsations with that. And also we're going to inspect the contour of the abdomen, so see if it's flat, rounded, protuberant, or scaphoid. Also note the symmetry of the abdomen, see if there's any visible organs or masses present, which there are none, so that's good. We're also going to inspect the umbilicus for signs of inflammation or herniation. Alright, so now we're going to move on to auscultation. So it's important to do auscultation before you do percussion and palpation so you don't alter the frequency of bowel sounds. So we're going to go ahead and listen with the diaphragm stethoscope in the right lower quadrant. Okay, now we're going to listen over all the vessels in the abdomen. So first we're going to listen over the aorta, and we're going to listen for bruits. Okay, now listen over the renal arteries. And the iliac arteries. And then the femoral arteries. Okay, now we're going to listen over the area of the liver and the area of the spleen for signs of rubs. And if rubs are present, it could suggest possible hepatoma, a gonococcal infection, or even a pancreatic carcinoma. Now we're going to move on to percussion. So we're going to percuss lightly in all four quadrants. Tympani should predominate in all the quadrants. We're going to let our percussion guide our palpation. Okay, now we're going to percuss the lower anterior chest, and we're going to percuss over the area of the liver, which should be dull. It's going to be on the right side on the costal margin, and on the left side where the gastric bubble should produce tympani. Okay, now we're going to move on to palpation. So first we're going to go light palpation, and then we're just going to put our hand, keep our hand and forearm in a horizontal plane, and we're going to keep our fingers together, and we're going to press down in a gentle dipping motion in all four quadrants. And we're just going to raise our hand just off the skin, enough to move on to the next location. And when we do this, we're going to be feeling for any tenderness or masses or muscular resistance. And it's important too when you do this to distinguish between involuntary guarding or involuntary spasms and voluntary resistance. Make sure we relax the patient so we can help differentiate between these two. So now we're going to move on to deep palpation. So if you detect any masses during light palpation, then this is good to delineate between those masses. And it's good sometimes to use two hands for this as well. It can help you get a better feel. Okay, so now we're going to move on to the liver. And so first we're going to percuss the vertical span of the liver in the right midclavicular line. So first we're going to identify the lower border of dullness. So we're going to start in the right lower quadrant below the level of the umbilicus. And we're going to percuss up till we hear dullness. Okay, so right there you make a mark. Now we're going to percuss the upper border. So we're going to start in the nipple line and percuss down until we hear dullness. Okay, so make a mark right there. So then the distance between these two would be the vertical span of the liver, again in the right midclavicular line. And typically this should be 6 to 12 centimeters for a normal healthy liver. So now we're going to move on to percussion of tenderness, just of a non-palpable liver. So I'm going to place my left hand flat on the abdomen over the right costal margin. I'm going to hit my hand with my fist. Okay, you have any tenderness there? Okay, so now we're going to compare sides. Any tenderness? Okay, good. So now we're going to move on to palpation of the liver. So I'm going to put my left hand under the patient and support the 11th and 12th ribs. Okay, now I'm going to use my right hand. I'm going to put a lateral to the rectus muscles. And we're going to press down with the right hand. And we're going to, starting with the right hand well below the area of lower dullness. And we're going to press down and in with the right hand. And go ahead and take in a deep breath. Okay, exhale. Good, so when we do that, we're trying to feel for the lower edge of the liver, which is usually around 3 centimeters below the right costal margin. Okay, now we're going to move on to the spleen. So when the spleen enlarges, it'll typically enlarge inferiorly, so down, medially, so towards the midline, and then anteriorly, so outward. And so also when the spleen enlarges, it can replace the tympany of the stomach and the colon. We're going to, you can usually detect it on percussion, but it'll usually confirm it with palpation. So we're going to first percuss this the left lower anterior chest wall, and we're going to start at the level of cardiac dullness, so right here at the 6th rib. We're going to percuss over to the left anterior axillary line. Now we're going to percuss down to the left costal margin. Okay, and tympany should be predominant there for normal size spleen, and that is termed trough space. So now we're going to check the splenic percussion sign. So now I'm going to percuss over the lowest intercostal space, right here. Now go ahead and take in a deep breath. Exhale. Okay, good. So, excuse me, whenever the patient does that, tympany should be predominant still, again, for a normal size spleen. So we're going to move on to palpation of the spleen. So I'm going to place my left hand around the patient and support the left rib cage. I'm going to put my hand below the left costal margin, and I'm going to press up or anteriorly with my left hand and down with my right hand. Go ahead and take in a deep breath for me. And exhale. Okay, good. So when we do that, we're just trying to feel for the inferior edge or the tip of the spleen. So now we're going to move on to the kidneys. So the kidneys are retroperitoneal and usually not palpable, but we're going to go ahead and give it a shot anyways. All right, so move to the patient's left side to palpate or attempt to palpate the left kidney. So I'm going to put my right hand below the patient, my fingertips at the costovertebral angles. I'm going to press down deep into the left upper quadrant with my left hand. Okay. Move on to the right side now. Place my left hand under the patient and fingertips at the CVA. We're going to press deep into the right upper quadrant with my right hand. And feel. Okay. So now if you don't mind, go ahead and sit up for me. Now we're going to check for tenderness by percussion of the kidney. So I'm going to place my left hand at the costovertebral angle and just strike my hand with my fist. Any tenderness?
No.
Okay, other side. Any tenderness?
No.
Okay, good. Go ahead and lay back down. So if the patient does have tenderness there, it could suggest pyelonephritis or pain of musculoskeletal origin. So next we're going to move on to palpation of the bladder. So when you palpate the bladder, if you can feel it, that means it's distended and it should feel round and smooth. We're going to just check for any tenderness. And usually you won't be able to feel it unless there's 400 or 600 mLs of fluid in the bladder. Okay, so now we're going to move on to percussion. So we're going to note and see if there's dullness that replaces tympany of the abdomen. If so, then that usually means the bladder is distended. And also we're going to measure the distance above the symphysis as well. again, it has to have about 400 600 mLs of fluid before you can hear that dullness replace tympani. Okay, awesome. So now we're going to move on to special techniques. So we're going to test for ascites. So now I'm going to have you just place your hand like this right here for me in the midline. Go ahead, I'll place it right there. Perfect. All right, go ahead and press down there. So I'm going to have my hand on one flank. I'm going to tap the other flank, and we're going to feel for the impulse on the opposite hand. And if this is present, then this could be suggestive of ascites. Okay, I'm going to go to the other side. Okay, don't feel anything. Awesome. So now we're going to move on and test shifting dullness. So I'm going to go ahead and have you roll over and face me. Okay, so if shifting dullness is present, then the dependent side should be very dull to percussion, and the top side should be tympanitic. Okay, good. Go ahead and put that down. Now we're going to assess for possible appendicitis. So first of all, we're going to check for rebound tenderness in the right lower quadrant. So I'm going to press down slow and then raise my hands up fast. You feel tenderness, push down, raise up. Okay, so if they feel tenderness whenever you raise your hands up, then that can suggest appendicitis. So now we're going to test Robson sign. So it's the same thing now in the left lower quadrant though. And this is referred rebound tenderness. Okay, do you have any pain with that? Okay, if she did have pain in the right lower quadrant from doing that, then that would be suggestive of appendicitis. So now we're going to perform psoas sign. So I'm going to put my right hand above the patient's right knee and go ahead and just raise your leg up. Okay, and does that hurt? Okay, if she had pain with that, then that could suggest appendicitis as well. That'd be a positive psoas sign. So last sign for testing for appendicitis is going to be obturator sign. So I'm going to flex patient's thigh at the hip, and then we're going to make sure the knee's bent. I'm going to internally rotate the leg, the hip. Any pain with that?
No.
Okay, if she did have pain in the right hypogastric area, that also suggests appendicitis as well. So now we're going to check for cholecystitis. So we're going to check for Murphy's sign. So I'm going to place my hand under the right costal margin. Go ahead and take a deep breath for me. Okay, exhale. Good. You have any pain with that?
No.
Okay, so if the patient were to stop breathing, they're going to have a sharp increase in pain, and that could suggest a possible cholecystitis as well. So next thing we're going to do is test for ventral hernias, and these are exclusive of inguinal hernias because these are in the abdominal wall and they're not in the groin region. So now go ahead and raise your head and shoulders up off the exam table. Okay, so we're looking for any bulges that may pop up because that will elicit those if there is a ventral hernia present. So now distinguish between that and an intra-abdominal mass. We'd have the patient strained down, and then if the mass is obscured because of muscular contraction of the abdomen, then that will suggest an intra-abdominal mass versus a mass in the actual abdominal wall itself. Okay, we're done here now. Go ahead and sit you up here. Take these from me. Do you have any questions for me?
No, I think that's it.
Okay, I'll go take my findings back to my preceptor, and we'll be back with you shortly. You have a wonderful day.
Thank you.